We're going to talk about medical documentation, particularly as it relates to E&M services. What are E&M services? Well, these are evaluation and management services, and they are common patient-physician encounters such as a clinic visit or an H&P. These do not include tests or procedures. The documentation guidelines for these have been issued by the Centers for Medicare and Medicaid Services, first in 1995 and then revised in 1997. They define an E&M encounter to have three key documentation components: the history, exam, and medical decision making. So the history, as defined by the 1997 guidelines, has four components: a chief complaint, a history of present illness, a review of systems, and a past family and social history. There are four history levels: comprehensive, detailed, expanded problem-focused, and problem-focused. The guidelines include a table that defines the requirements for each level of history. For example, a problem-focused history for a new patient requires a chief complaint and a past family and social history, whereas a comprehensive patient history requires a chief complaint, a history of present illness involving four elements or the status of three chronic conditions, a review of systems for 10 body systems or body areas, and a past family and social history. The HPI elements that I'm referring to are things like location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms for the reason the patient is being evaluated. So this could be chest pain, where it is located, how severe it is, how long has it been going on, in what context did the symptom develop, such as with exercise, and what are modifying factors, such as rest or nitroglycerin in the example of chest pain. A review of systems can have as little as one system, though for a comprehensive history you need to document data for 10 systems. The systems are defined as constitutional, eyes, ears, nose, and throat, cardiovascular, respiratory, GI, genitourinary, musculoskeletal, integumentary, neurologic, psychiatric, endocrine, hematologic, and allergic. For the past family and social history, there are three areas: the past history, which includes medical and surgical history, social history, and family history. Many insurers will not accept non-contributory for past family and social history. If something is unknown, such as a patient who may not know his family medical history, state clearly that the patient does not know any details. Established patients are a little different, and there's a separate table for established patients. Primarily, you end up having to document less for past family and social history, and you can refer to a previously documented past family and social history. But it's important to note that the chief complaint, history, present illness, and review of systems is usually required. We're going to go on to the physical exam section. The 1997 guidelines document a wide range of physical exam subtypes, such as a cardiovascular exam, an eye exam, a psychiatric examination. These are very tailored to the needs of physicians that are primarily dealing with a narrowly focused evaluation of the patient. For many patients that a primary care provider would see, you'll be performing what's called a general multi-system examination, and that's the basic type of examination that we were taught to do as medical students and residents. Again, there are multiple exam levels: comprehensive, detailed, expanded, problem-focused, and problem-focused. And there are specific requirements for each levels. We're going to talk primarily about the 1997 guidelines and the general multi-system examination. If you want to look at any of the details for the specialty examinations, such as cardiovascular, please refer to the 1997 guidelines so you can review that. For a general multi-system exam for problem-focused, you need really one bulleted item, usually examining whatever body area the patient came in to be evaluated for. And this is in contrast to a comprehensive examination, which needs two bulleted items from 9 organ systems. The medical decision component of an E&M encounter is also known as the assessment and plan. This has 3 components: the number of diagnosis or management options, the amount or complexity of data, and the risk of complications, morbidity, or mortality. There are 4 medical decision-making levels, which are high, moderate, low, and straightforward. And if you look at this table, the complexity of medical decision-making is set by the highest 2 of the 3 areas involved, such as a high complexity medical decision-making note needs to have the documentation of extensive diagnosis and treatment options and extensive data reviewed, and it may have moderate risk. You could also, for the same complexity, document extensive diagnostic or treatment options, moderate or low data reviewed, and high risk to the patient, because it's the highest 2 of 3 areas. Unfortunately, there's a problem with medical decision making, and the criteria for what qualifies for an extensive amount of data reviewed or extensive diagnosis or treatment options are not defined in the E&M guidelines. Medicare carriers can decide how to interpret these levels. Most Medicare carriers use this method. For the determining the diagnostic options level, they allow you to earn a maximum of 4 points. So a new problem with a workup it gives you 4 points. A new problem without workup is equal to 3 points. An established problem that's worse, 2 points for each problem. So if someone comes in with uncontrolled diabetes that's established and established uncontrolled hypertension, you would get 2 points for each problem for a maximum of 4. Also an established problem that is stable, you get 1 point for each problem. And minor problems or self-limited problems are worth 1 point apiece, but you can only get 2 points in that manner. Unfortunately, the majority of primary care patients seem to be presenting with a new problem requiring workup, which is 4 points, and 2 or more established problems which may be stable or worse, which would be, possibly 8 points or more, but you can only get a maximum of 4 points. Determining the data level, again, has a ceiling of 4 points. Reviewing old records and making a summary of that will earn you 2 points. Interpreting an image or tracing like an ECG, 2 points. Requesting old records, 1 point. Discussing the patient with another physician, 1 point. Reviewing or ordering an imaging study, test, or other tests such as an EKG or a pulmonary function test will get you 1 point apiece. There is no double credit, so you can't take credit for ordering and reviewing a chest x-ray. You pick one or the other. Then for assessing risk, the 1997 guidelines has a very large table of risk, which is based on the presenting problem, diagnostic procedures that you may consider, and management options. It's a very lengthy table with a lot of detail. There are a couple of things to remember. A presenting problem that is an acute or chronic illness or injury that threatens life or limb is a high-risk situation. Abrupt changes in neurologic status is high. A new problem with an uncertain prognosis is moderate. Management options, things like parenteral controlled substances or drug therapy requiring intensive monitoring, are high, and the management of any prescription drugs really qualifies as moderate medical decision-making risk. So remember, with your medical decision-making, it's set by the highest two of the three areas. I would encourage you to consider always selecting the risk involved to your patients as one of those areas that you take the time to document clearly. So now with this information, we can move on to how you determine E&M service levels. If you look at a new outpatient visit, level 5, you have to document a comprehensive history, a comprehensive exam, and high medical decision-making. For a level 1, in contrast, problem-focused history, problem-focused exam, and straightforward medical decision-making. If you think back to medical decision-making, someone who's on any prescription medication will have moderate medical decision-making, so that means they'll probably be level 4 as an outpatient visit. For established outpatient visits, it's a little different, where you have to meet 2 of the 3 components at this level, meaning history, exam, or medical decision-making. So for a level 4 outpatient visit, you could document a detailed history and a detailed exam and have low medical decision-making and still qualify for the level 4 established outpatient visit. However, I would strongly recommend that you make sure that your medical decision-making is at the level required for the level of service you're billing. There's similar leveling for other E&M services, such as emergency department visits, inpatient visits, observation status, and nursing facility visits. So why is this important to you as a physician or healthcare practitioner? It's because of the compensation models that's used by most practices, where you have a base salary, some sort of production or productivity component, and when those are added together, it provides you with your overall income. When you look at the level of service for a hospital admission, if you go from a level 3 admission, the Medicare allowable charge is $204, which is 3.86 relative value units. In contrast, a level 1 E&M encounter for a hospital admission has a Medicare allowable charge of $102 and is only worth 1.92 RVUs. So if you're providing a level 3 service, you should be billing for that service so you can be paid for the work you're actually doing. Medicare changes and changes to other insurers are changing the sources of revenue, making it a quantity and quality-based compensation system. And this is really important because of the triple challenge facing healthcare today of cost, quality, and value.